Osteoarthritis is a common cause of hip disability and the primary reason for a hip replacement. Osteoarthritis is a byproduct of age-related wear and tear, and this can result in pain, stiffness, loss of mobility, and deterioration in function. The hip consists of a ball and a socket joint. The round head of the thigh bone, also known as the femur, moves within the socket of your pelvis, called the acetabulum. It is the ball and socket structure of the hip joint that allows you to move your hip in multiple directions. With osteoarthritis, cartilage within the hip joint softens and wears away, causing the bones to rub against each other. This can result in considerable pain and stiffness. Other reasons for hip replacement surgery include inflammatory arthritis, post-traumatic arthritis, an acute fracture within the hip, avascular necrosis, or childhood hip disease. Proper assessment of the patient is crucial to determining whether hip replacement surgery is the correct treatment option. This may include a review of the patient's general health, a physical examination such as looking at leg lengths, review of the patient's social status, as well as thorough review of the patient's x-rays. The x-ray on the left shows an anatomically healthy hip. However, the x-ray on the right shows a diseased hip joint, as evidenced by the joint space narrowing, the bone spurs, and the cysts on the acetabulum and in the femoral head, features consistent with osteoarthritis. Surgery may not always be the best method of treatment for hip disease. Non-surgical treatments include lifestyle and activity modification, physical therapy, the use of assistive devices such as a cane or a walker, the use of medications, or possibly injections. The surgical option is a total hip replacement. Hip replacement surgery involves an orthopedic surgeon replacing your diseased hip joint with an artificial prosthesis. This involves cutting out the head of the femur and replacing it with a ball and stem. While there is no absolute indication on whether surgical treatment is required, some indicators include the hip as the primary source of pain and disability, this disability affecting the patient's quality of life, the patient understanding the risks of surgery and anesthesia relative to their benefits, the patient being willing to accept those risks, and there being no predicated contraindications to surgery. The patient's journey will include 9 steps: an initial orthopedic consultation, referral to the new joint program, going on the surgical wait list, optimization to include medical and anesthetic consultations, including review of lab tests, assignment of a surgical date, an educational class, completing the preoperative testing, the surgical date and the hospital stay postoperatively, physiotherapy, and the recovery phase. The prosthesis used will consist of multiple components. These include a femoral stem and head that will replace the head of your damaged femur, a plastic-lined prosthetic cup that will be used to line your acetabulum. These components are fit together to create a ball and socket structure joint. This is what allows you to move your hip in multiple directions. There are a variety of fixation methods used to fit your artificial hip components to the bone. These include cemented, using a quick hardening adhesive, uncemented, where the bone grows onto the surface of the artificial hip, or a hybrid, which involves a combination of the two. All 3 of these methods of fixation are successful. A variety of factors, including age, disease type, and bone quality, will determine the choice of fixation used to fit your artificial joint in your body. There are a number of surgical approaches to total hip replacement surgery. Not one approach has any proven benefit over the other. Proper component positioning is important in assuring the long-term survival and functionality of your hip prosthesis. This will be prioritized over the approach and length of incision. There are also a variety of bearing surfaces that may be used in your hip prosthesis. The majority of these will include metal on plastic, also known as polyethylene. Others include ceramic on plastic, ceramic on ceramic, hip resurfacing, or a dual mobility prosthesis. The majority of hip replacement patients can be discharged safely within 48 hours. Factors that facilitate a rapid discharge include preparation, pain control, family and social supports. The joint replacement program will assess and assign your length of stay as follows: fast track within 1 to 2 days of discharge, routine stay up to 3 days, or extended stay to include rehabilitation or convalescent care.
Total hip arthroplasty, also called total hip replacement, begins with an incision to allow access to the bones of the hip joint. The next step is to remove damaged cartilage and bone from the acetabulum, the cup-shaped hollow in the pelvic bone. This damage results from the bones rubbing directly against each other when protective cartilage wears away. A tool called a reamer is used to prepare the acetabulum to receive the socket portion of the hip replacement. This metal and plastic combination is called the acetabular component and is fitted into the newly reamed bone surface. The outer metal part of this component, sometimes called a cup, fits directly into the socket. The inner plastic portion has a hollow to hold the replacement for the ball-shaped bone at the top of the thigh bone or femur. The outer metal part is rough to help bone grow into its surface over time to lock the artificial socket in place. The next step is removing the ball-shaped head of the femur or thigh bone and preparing the femur for placement of the stem portion of the component. A metal ball is attached to the end of the stem and fits into the artificial socket in the hip bone. Together, these components replace the natural ball and socket joint. During and after surgery, the surgeon verifies the correct fit and range of motion of the hip replacement components. By mimicking the anatomy and functioning of the natural hip joint, hip replacement can reduce pain and permit a return to many activities.
Over 80% of patients will experience significant to complete relief following hip replacement surgery. It is expected that 90% of hip replacements will function well for 15 years. Some potential complications following hip replacement surgery include residual pain, either local or referred, a residual limp, leg length inequality, early failure due to factors such as poor bony ingrowth, dislocation, wear, and component failure, medical complications such as pneumonia, heart attack, or a stroke. Additional complications include bleeding, which may require a blood transfusion, infection, blood clots, and related conditions known as deep vein thrombosis and pulmonary embolism, fracture around the prosthesis, or damage to the muscles, nerve, and blood vessels. The wait time for your hip replacement will depend on several factors. These include the severity of your hip disease, your general medical health, and the amount of operating room time allocated to joint replacement surgery. Current recommendations are for hip replacements to be performed within 6 months of booking. The current wait time is well beyond that benchmark. You may change surgeons to have your hip replaced by a surgeon with a shorter wait list. The Rebalance surgeons have agreed to a first available appropriate surgeon triage, also known as FAST 2.0. This allows patients the ability to decide to have their surgery performed sooner by another trained orthopedic surgeon rather than waiting on a longer wait list. This may result in a significant reduction in wait time. Most current hip replacements are comparable. By using hip registry data to assess early failures, we are confident the prostheses we are using are amongst the most durable available. In selected individuals, alternate bearing surfaces such as ceramic on plastic, ceramic on ceramic, and hip resurfacing may be considered. These technologies are considered non-standard and have an added cost attached to them. There are also unique characteristics and complications associated with these alternate bearings one needs to consider. For most patients, the stay for an uncomplicated hip replacement can be accomplished safely within 48 hours. In order to accomplish this, preparation for discharge on day 1 or 2 needs to be completed before admission. The actual discharge date will depend on the individual patient's clinical status and recovery. Unfortunately, due to scarcity of hospital resources, prolonged stay for convenience or social issues is not possible. If there are concerns, arranging additional private home supports or respite care may be an option. Please discuss these with your navigator. Being able to drive safely depends on the leg operated, the use of an automatic or a standard transmission, and your ability to safely navigate your foot from gas to brake. Some general guidelines are as follows. You should be off all narcotic medications. A minimum of 6 weeks if it is your right leg. Your ability to safely stop in an emergency. Please discuss this with your surgeon and/or physiotherapist at your post-operative visit. Remember, your artificial hip is artificial. While some patients say their prosthetic joint feels as good as new, most patients will say it feels different. It is also important to realize being artificial, your new joint is subject to wear and does not have the ability to heal the way a non-artificial hip does. It is difficult to give an absolute number on how long your new hip will last. In general terms, if the hip surgery is performed successfully, there is a 90% or greater expectation that your new hip will survive more than 15 years. Like any mechanical bearing surface, wear of the artificial hip is related to the quality of the surface and the amount of use, like tires on your car. Potential options to decrease wear include a ceramic bearing surface and moderate use. There are some controversies as to what are acceptable and unacceptable activities after hip replacement surgery. Generally speaking, non-impact activities that avoid extremes of range of motion are recommended. Meanwhile, high impact, contact, or activities that require extreme flexion or rotation of the hip should be avoided. Some activities that are allowed after hip replacement surgery include walking, speed walking, hiking, road cycling, swimming, canoeing, kayaking, sailing, square or ballroom dancing, low impact water aerobics, bowling, and weight training. With some experience, you may also find yourself comfortable with ice skating or non-contact hockey, cross-country and downhill skiing, doubles tennis, horseback riding, rowing, Pilates and gentle yoga, or inline skating. As high-impact activities or those that require extreme flexion or rotation of the hip should be avoided, we do not recommend singles tennis, handball or squash, rock climbing, volleyball, basketball, football, soccer, jogging or running, baseball, martial arts, high-impact aerobics, and contact hockey.